Hello, my name is Dr. Roger Henderson, and I'm a GP in southwest Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all of those of us working in primary care. Now, you can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me there too, at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, this episode's been requested by our listeners, and as always, GPnotebook is very keen to hear the opinions and requests of all of you, so do please contact us for suggestions for future episodes. But in this episode, I'm going to be discussing celiac disease. Now, as we know, celiac disease, or CD, is an immune-mediated, inflammatory, systemic disorder found in genetically susceptible people, and it's provoked by gluten, the protein found in rye, barley and wheat. Now, this can lead to significant nutrient malabsorption and marked symptoms if undiagnosed and untreated. Now, it affects all ethnic groups and all ages, but it often comes as a surprise that 1% of the UK population has celiac disease. But a bigger kicker is that we think around 80% of this group remain undiagnosed, partly because of the wide variation in individual symptoms and signs, and also because, as we know, some people with celiac disease may be asymptomatic. As a consequence of this, there may be significant delays from celiac disease symptoms developing to the time that an accurate diagnosis is finally made. And in my experience, this can sometimes be years. Now, since 1970, the prevalence of celiac disease has slowly but progressively increased. And this is likely to be due to an increased use of diagnostic testing, as well as a better overall awareness of the importance of screening people at high risk of this condition. Now, the 2015 NG20 NICE guidelines on celiac disease were published in September 2015, but updated in early 2020 to include the Department of Health's advice on vaccination against pneumococcus for people with celiac disease. More recently, the European Society for the Study of Celiac Disease published recommendations on managing the condition and other gluten-related disorders in adults and children. And I thought I'd sort of give us a general overview on we need to refresh our thinking about celiac disease on the back of that. And the first thing I'd say is that we should always remember that gluten ingestion can be associated with a significantly wide range of clinical disorders. So we know that celiac disease is a chronic, multigenetic, multi-organ autoimmune disorder associated mainly with HLA type DQ2 or DQ8, affecting the small bowel in people genetically predisposed to it. We also know that gluten ingestion is now being linked to a range of potential clinical conditions known collectively as gluten-related disorders. And we can subdivide celiac disease now into categories such as refractory, slow responding, and seronegative, depending on the clinical and immunological factors present. Up to around a third of adults with celiac disease continue to have persistent symptoms, though, or signs or laboratory abnormalities, despite having a gluten-free diet for at least 6 to 12 months. We also should remember dermatitis herpetiformis, the skin manifestation of CD, where you get herpetiform-like clusters of itchy papules with associated urticaria developing, along with deposits of IgA in the dermal papillae. Now, these do usually slowly clear once gluten's withdrawn from the diet, although there may be cases where it remains despite that occurring. Non-celiac gluten sensitivity causes irritable bowel-like syndrome-type symptoms that develop hours or days after the ingestion of food containing gluten, but those symptoms rapidly improve on gluten withdrawal and relapse after a gluten challenge. Less commonly, gluten ataxia is a sporadic ataxia in association with a positive celiac serology. And celiac disease can also be linked to other disorders, including peripheral neuropathy, epilepsy, depression, and even dementia. Now, who should we be testing for celiac disease? Well, the recent European Society guidelines strongly recommend that anyone with symptoms, signs, or laboratory evidence suggesting malabsorption should be serologically tested for celiac. And the screening of asymptomatic first-degree relatives of a patient with CD is also recommended. So looking at the groups of people we perhaps should be offering testing to, then I'd be thinking of things like unexplained prolonged fatigue, persistent unexplained gastrointestinal symptoms, and these are often attributed to irritable bowel, by the way, poor growth, unexpected weight loss, persistent oral ulceration, unexplained B12, folate, or iron deficiency, and anyone with type 1 diabetes and autoimmune thyroid disease, both at diagnosis and at regular intervals from then. We should also consider serological testing for anyone with a metabolic bone disorder, anyone with unexplained and persistently raised liver enzymes, females with unexplained subfertility or recurrent miscarriages, and in Downs or Turner syndrome. So when considering the diagnosis, serological testing is the gold standard. The preferred single test to detect celiac disease at any age is the IgA transglutaminase 2 antibody test, or IgA TG2. And this should be undertaken in laboratories with clinical pathology or ISO accreditation. Now, the lab should first test for total IgA TG2 as the first choice of test, and use endomysial antibody testing, IgA EMA, if these are weakly positive. Now, any diagnostic serological tests should always be done while the patient is on a gluten-containing diet. And in young people and adults, a positive serological test result is defined either as an unambiguously positive IgA test alone, or a weakly positive IgA, but a positive IgA EMA test. So the confirmation of celiac disease as a diagnosis should always be based on three things: clinical findings, positive serology, and duodenal histology, because positive serology plus villus atrophy is diagnostic confirmation. I think it's very important to remind ourselves that improvement or exacerbation of symptoms after gluten withdrawal or reintroduction actually has a very low predictive value, and so that should not be used to make a diagnosis of celiac in the absence of other supportive evidence. Now, if we get a patient who has negative serological testing, but you still suspect celiac disease as a diagnosis, then refer to your local gastroenterology specialist for further assessment. We should also be telling our patients that any test for celiac is only accurate if a gluten-containing diet is eaten during the diagnostic process, and that they shouldn't start a gluten-free diet, however tempting it is, until their diagnosis has been confirmed by a specialist, even if their serological tests are positive. A really, really important point. And they should also aim to eat some gluten in more than one meal each day for at least 6 weeks before being tested. Now, if we do have a patient who is reluctant to eat gluten before being tested, and we do get that for understandable reasons, then just refer that patient to a gastroenterologist, but do explain to them it may be more difficult to confirm the diagnosis by intestinal biopsy. So, obviously, young people and adults with positive CD serology should always be referred to a gastroenterologist for endoscopic intestinal biopsy to confirm or exclude the diagnosis, and that should go without saying. But serological testing should not be performed to simply determine if gluten has been excluded from an individual's diet. And if we're talking about diet, we must remember treatment with a lifelong, strict, gluten-free diet is currently the only known effective treatment for celiac disease. Full stop. Patients should be educated to avoid any cereal or food product derived from wheat, barley or rye, including gluten-contaminated cereal foodstuffs that are normally gluten-free, and that can include things like oats and maize. However, oats that are uncontaminated by gluten are very safe for almost all patients with celiac disease, although there may be a very small percentage who remain sensitive to them and who develop symptoms if ingested. Referral of our patients to national and local specialist celiac organisations and to dietitians with specialist knowledge of celiac disease is always helpful, and that should be something we should always be doing as a matter of routine. We must also remember that micronutrient deficiencies are common in celiac disease, and not only that, we should be testing for them on diagnosis. So any patient with a new diagnosis of celiac should be tested to check for deficiencies in essential micronutrients. And of course, we mustn't forget that a gluten-free diet itself has some nutrient limitations. About 4 out of 5 patients with celiac will have an iron deficiency at diagnosis. And in fact, celiac is present in about 5% of people with all iron deficiency anemias, but this does improve on a strict gluten-free diet, as does vitamin B12 deficiency, found in just over a third of cases of untreated celiac. Now, malabsorption linked to celiac also often leads to an inadequate intake of calcium, vitamin B6 and vitamin D, and around a quarter of patients with celiac have osteoporosis of the lumbar spine compared with about 5% of matched controls. However, vitamin D and calcium levels do usually normalize within 2 years of following a strict gluten-free diet, but these should be supplemented in patients with celiac and low serum levels of these, or those with loss of bone mineral density, or those who can't achieve an adequate intake via diet for whatever reason. You should not need long-term supplementation with zinc, because zinc deficiency can be present, but this does usually resolve completely on a strict gluten-free diet. Now, finally, we mustn't forget the importance of longer-term follow-up. All patients diagnosed with celiac should be encouraged to join national celiac societies or support groups, as I mentioned. And in the first year following diagnosis, follow-up should occur regularly in order to monitor dietary adherence, to provide psychological support, and to answer any questions that the patient may have. Now, once celiac's been stabilized and dietary alterations have become routine for that patient, then either annual or biannual follow-up is advised, along with checks for things like thyroid disorders and liver disease, and antibody checks to assess dietary adherence. The key endpoint here that we're aiming for is the absence of any symptoms and full mucosal healing. So it's entirely reasonable to do a follow-up biopsy in adults 1 to 2 years after starting a strict gluten-free diet to assess that, especially in those patients who initially presented with severe symptoms or in those aged 40 and above. So I do hope you found that overview of celiac disease helpful and as a reminder about what we should be doing in practice as a matter of routine. But do please have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts such as this one. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of all of our patients in primary care. But as always, until the next time, thank you so much for listening, and goodbye.